All right, we're here at Your Amigos Live 2025. We just got off the stage. We had a great novel therapy session, and we talked about cellular therapies as part of that. Not the only thing, but we talked about cell therapy. Brief introduction. I'm Brian Rini.
Monty Powell, winner of the Your Amigos North America Cup.
Hans Summers.
And you guys were around for the kidney cancer session. Monty, I'm going to ask you to start. We've come a long way, I think, in cell therapy and kidney cancer. I think it's one of the areas of excitement. I know you've been involved in some of the CAR T and bispecific studies. Talk about CDX-130, which I know is a first-generation CAR T cell.
Yeah, so, I would caveat this by saying we didn't have a ton of patients, 14 patients on the study, but nonetheless, very well-tolerated drug, very limited CRS and so forth. We only ended up with one patient responding, but it was a very durable, complete response, lasting out to 4 years at last report. So I thought it was a great signal. There is a new iteration of that, CTX-131, with some modifications to maybe help with T-cell persistence, but that data hasn't been released yet.
Okay, but that novel formulation is in a trial in RCC now.
It is, yeah.
Okay.
It is, yeah, CTX-131.
And let's tell us about the Allo316 CAR T, and then Hans, I'm going to ask you to comment on both of them.
Yeah, so I'll tell you, the Allo316 CAR T is very different, although it's also CD70 targeting. It actually has this edit out of CD52. So in earlier iterations of the study, you'd actually administer Allo316 with an anti-CD52 CAMPath-like drug, which I think added to a lot of toxicity, a lot of lymphopenia, long-term sort of cytopenias. And ultimately, that was observed even in the final cohorts of the study. They did have a response rate of 25%, as you pointed out. But having said that, I will say it came with a lot of toxicity. I think it's a really complex regimen that doesn't sort of stack up well with the targeted therapies that we're used to using in the RCC clinic.
The CAR T product, you think the Allo316 has too much tox, so more activity but more toxicity.
That's my impression.
Which is sometimes the story of cell therapy. So Hans, you've been in the immunotherapy field for a while. You're described as an immunotherapist by Dave McDermott today, which is quite a compliment, I might add.
That's true.
What do you think? Where do you think we are? Are we close to sort of having that breakthrough where this is going to be part of our armamentarium? Are we still in the little signals here and there? Are we still early on?
I think with CAR T cells, we still have to learn, and I think we still have to make it more user-friendly for the applying physicians, and certainly I think more tolerable to patients. I sent a number of patients actually to the 316 trials at MD Anderson, and I would say patients came back a little bit washed out. So you have a conditioning regimen, you have some blood count toxicity after that. That's not necessarily inconsequential, but it's also something that I would not use early at this time. That is the therapy that I tend to use rather later in the treatment.
So David McDermott in our session was making the point that if these are going to be successful, we need to use them early, because if you're 7th, 8th line and the immune system's exhausted, et cetera, but you're saying that you're a little uncomfortable using them early.
I think he meant the bite that Monty mentioned later.
Okay.
I think he meant the bite.
Okay. I thought he meant all of it, but maybe, I don't know.
Yeah, the CAR T cells, to be honest with you, there is so much toxicity, and I have not seen these durable responses yet, with some exceptions maybe.
Yeah.
I still think that immune checkpoints carry the day in the front line, second line type thing.
You're not there yet.
Not there yet.
Yeah. Monty, what do you think? Would you give a second-line patient a CAR T product?
I try to maybe get through the first couple of dose
Yeah.
levels of the drug, but after that, I'd be totally fine giving a second-line patient an experimental therapy, provided it had demonstrated to date an acceptable toxicity profile.
Yeah, I think I would. I've not used a lot of these, but I think I would in the right patient. We all have those 47-year-old, very healthy, and they kind of blow through Ipi-Nivo, then Cabo, and I find patients that don't really respond to the first two lines, they're not really going to respond to anything. You might have a little tumor shrinkage, but so anyway, I would be more aggressive in those patients. But I think it's fair to say, and I think the summary of that part of the meeting was that we're excited. We need novel mechanisms in this disease, but the signals, there's some early signals, but also some toxicity concerns. And I guess maybe the last thing to mention is the ENPP3 bite that you've been involved with.
Well, I hadn't heard a lot about ENPP3 prior to this trial, but it's a very sort of pervasively expressed antigen in renal cell carcinoma. There have been ADC studies looking at it previously. And with this bispecific, I will say that we saw actually a reasonable amount of activity. It's a bit of a labor of love because you have to go through so many dose levels with these compounds to get to your target dose. We went through, now we're at the 10th dose level of the agent. But we're finally at a point where we're starting to see some real activity. And although, that first month of therapy when you're encountering CRS and escalating the dose can be a challenge. After that, my personal experience is that it's been smooth sailing for patients.
And that's the story of high-dose IL-2 and Ipi/Nivo, right? Immune therapy in
Actually, it's
general,
true,
right?
yeah.
Is there's this mountain of toxicity, and then once you get over it, people kind of cruise, obviously, if their disease is under control. So which of what we talked about are you most excited? Or something we haven't talked about?
I do think from a practical standpoint, the bispecific probably has the strongest legs at this point.
Benefit risk, maybe.
I like the bites. And I think the benefit risk is ready for early use, even in frontline use, I would say, in combinations.
For bites?
For bites, yeah.
Okay.
Yeah.
All right.
That's where they work well in small cell lung cancer, for example. Right?
Yeah,
So,
yeah. We'll probably learn a lot from
Yeah,
that
yeah.
field. So anyway, thank you guys for joining. Appreciate it.
You got it.